Hey guys, so another JG extra coming at you. This one was actually requested by one of the faculty because there was apparently a recent case of hypothermia, and so this was kind of serve as a refresher as we go into the cold months. Some of you may remember the sim case that we had last year, but and those of you who don't, or those of you new to the program, then this will serve as a refresher also. Instead of the cat meowing this time, we may have the laundry in the background, but hopefully it's not too loud. So with that, let's get started. I think you guys remember the movie Titanic that this picture probably comes from. So anyways, we'll get started with hypothermia. As far as the basics, remember that hypothermia is defined as a core temperature of less than 35 degrees Celsius. And just because you don't live at places that have extreme temperatures, like Antarctica in this case, maybe, remember that you can still very likely encounter patients with hypothermia, especially as we get into the cold months. Most people who die from this are likely to be over 65 years old, and then remember from basic physics the four methods of heat transfer, which we won't get into right now. But anyways, also another basic thing is remember that the hypothalamus is the control center when in regards to temperature in the body, and that cold in the body can, among other things, lead to vasoconstriction, behavioral changes, shivering spontaneously, and an increased basal metabolic rate. So many causes of hypothermia, such as stroke, drugs, alcohol, hypopituitarism, hypoadrenalism, hypothyroid, metabolic. Sepsis is another one to keep in mind. Remember that in not just fever, but also hypothermia is one of your SEERS criteria. But the main one that we'll probably encounter is the accidental/environmental hypothermia. This can be further subdivided into those cases that are secondary to immersion in water and non-immersion. When it comes to water or immersion, anything like rain and cold water swimming are going to be your biggest risk for this. Interesting point about this is that if a victim drowns in cold water, they actually have a better prognosis than those who drown in warm water. And this is because if the patient is still able to breathe and the cooling happened before the onset of hypoxia, they've shown that they have a better prognosis versus those who are unable to breathe before the cooling happens. And an interesting random fact is that the longest documented case of a patient who survived with no neurological impairment in a submersion case was a 2.5-year-old kid who was submerged for 66 minutes in cold water, and when they found him, his initial temperature was 19 degrees Celsius or 66 degrees Fahrenheit, core temperature. So pathophysiology, everyone's favorite topic. Just remember that a few of the basic responses kind of vary from person to person, but overall there's a few general ones that we'll talk about that occur in every person. In mild hypothermia, and that's defined as a temperature from 32 Celsius to 35 Celsius, initially you're going to start to get, in this phase, you're going to get what's called the excitation phase. And basically the body is going to be making certain physiologic adjustments to try and cope with the decrease in core temperature. Main three are going to be increasing the heart rate, cardiac output, and the systemic vascular resistance by vasoconstriction. That's going to give you an increase in your blood pressure. And as you start to get a drop in your temperature, then these are going to start to decrease also. So once you get to 32 degrees Celsius and below, then you're going to start to go into a slowing phase, which is going to get an overall global decrease in function and metabolism of the different organs, cells, etc. In the body. The goal with doing that is that you are going to decrease the oxygen utilization and CO2 production. Once you get below 30 degrees, shivering is actually going to be lost. The muscles just can't carry out that function anymore. And the temperature is going to cause negative inotropic and chronotropic effects on the heart, and so you're going to get a decrease in cardiac output and also blood pressure. And then we'll talk about how the circulating volume can also decrease. Acid-base changes are common when the respiratory function starts to get depressed, then your ventilation is going to go down, so you're going to start to retain carbon dioxide. And then also in the periphery, because the muscles are shivering and they're not getting great oxygen delivery, they're likely going to switch into anaerobic metabolism, and so they're going to start to get a large production of lactate throughout the body. There can be a minor component of alkalosis because of the decreased CO2 production, but this is probably going to be overwhelmed by the acidosis. And then remember from probably first year of medical school, I'm sure you all remember this chart here, which is basically saying that with a decreased temperature, it's basically going to be harder for the oxygen to get dissociated from the hemoglobin and delivered to the peripheral tissues. And then remember, of course, that as you start to decrease your temperature, one of the other organs that starts to depress function is the brain, and so you're going to get an eventual coma because of the CNS suppression. So why do you get the decrease in blood volume? There's two main reasons. One is that the kidneys themselves are going to start to lose their concentrating ability, and the pituitary is also going to start to release less antidiuretic hormone. So both of these are going to cause a cold diuresis, and so that's why you get your volume loss and hemoconcentration from that. Remember to keep in mind that these patients are, as they get more and more severe hypothermic, they can become immobile, and this can, because of the renal hypoperfusion from the vasoconstriction, and then also if there is cellular damage that releases myoglobin, causing myoglobinuria, these patients are at risk of developing rhabdomyolysis and acute renal failure. And then last thing is the hemoconcentration from the volume loss is going to give you increased blood viscosity, and that coupled with the poor circulation and cold-induced coagulopathy that they're likely going to be suffering, they can be prone to embolic complications and thrombosis. There is a New England Journal that I'll attach on the email review paper on hypothermia, and one thing that they show is that there is a Swiss staging system of hypothermia. And they basically split hypothermia up into 4 stages, 1, 2, and 3, based on the temperature and on the clinical symptoms. So if you don't have a thermometer for some reason, let's say you're out in the field, you can kind of tell what stage of hypothermia they're in based on what they're exhibiting. I'll let you guys read the paper for the further details. As far as EKG changes, you can see here one common finding on the EKG is the J waves. They happen just after the QRS complex. And then as far as changes, other rhythm changes that occur, most of these patients are going to progress from bradycardia. They can then go into an atrial fibrillation with a slow ventricular response, and then into a ventricular fibrillation, and then into asystole. A few interesting random tidbits is that one thing to keep in mind is that if the patient is an alcoholic, the Wernicke's can actually cause hypothalamic dysfunction. And so one thing you can think about giving to your patients is thiamine, as this can help the Wernicke's and the underlying mechanism of the hypothermia. Remember that alcohol is a vasodilator, and that coupled with the CNS effects is going to cause that the patient is not going to feel their cold as well as they would if they were not intoxicated. And then remember again that sepsis can cause hypothermia just because it's going to reset the hypothalamic set point. So the main question, I'm sure you guys are wondering with this JG X-ray, is what to do in the case of a patient with hypothermia. One, of course, you're going to want to get them out of the cold environment that they were in, get any wet clothing off, and once after you do that, of course, dry the patient. You do want to handle the patient gently. The reason for this is that the hypothermic myocardium is irritable, they say, and it's prone to ventricular fibrillation and asystole. So you want to move the patient around gently when you're transferring them from the EMS gurney to the stretcher, and when you're moving them around, getting the leads on, etc. Be gentle when you're moving them. Another thing is that you want to take a little bit of extra time, maybe than you would in your non-hypothermic patient, in trying to detect a pulse and look for respiratory activity. Just remember that they may be very bradycardic, and so if you don't feel a pulse within the first few seconds, you don't want to just jump on their chest and start doing compressions because of the irritable myocardium we talked about. You can actually make a slightly bad situation of just bradycardia much worse if you put them into ventricular fibrillation. So you can think about getting ultrasound to help double check if they truly are asystolic. As far as treatment goes, remember that giving them warm oxygen and fluids is helpful. We'll talk about more details in a second. As far as monitoring their actual temperature, you want to get as close to the core measurement as you can. So a rectal probe is probably your easiest and best option. If you have an esophageal probe, these are actually better to do. They're a little bit more accurate. Remember that the pulse ox may be falsely low because of vasoconstriction. And if you're going to put a central line in your patient, think about using a femoral central line better than either an IJ or a subclavian. The reason here is because, again, when you're putting in the central line, using that guide wire, if you go in IJ or subclavian, you can theoretically irritate that myocardium to the point where you put them in, put them into ventricular fibrillation. As far as if they need intubation, just do it. The irritability of the myocardium has not been shown to be a big problem with intubation. Just remember to make rewarming the patient your second big priority if they are also in a dysrhythmia state. Remember to thinking about giving thiamine to your patients. When it comes to antibiotics, steroids, thyroid hormone, etc., hydrocortisone, think about that on case-to-case basis. Excuse me. As far as rewarming techniques, more specifics, after passive, remember you can do warm water immersion, though in the ED this is pretty difficult, and overall that's pretty difficult. So easier things that you can do is just heat up the room that they're in, reset the thermostat in the room. And if you have heat lamps, those are great. And in addition to bear huggers, we're all kind of familiar with that here at our program. Warm blankets is a great addition. And as far as how high should you warm the fluids to, a good temperature that they recommend is 104 Fahrenheit, 40 degrees Celsius. But the New England Journal paper actually says that you can go up to 42 degrees Celsius or 108 Fahrenheit. Next, you can progress to doing warm water bladder irrigation, again with a temperature of 104. And then if you're giving oxygen, you can think about warming that oxygen, giving warm humidified oxygen either through the nasal cannula, face mask, non-rebreather, or endotracheal tube. You're only going to get a small amount of gain from in respect to heat, but you prevent up to 30% loss of heat with that. And the air should also be heated to about 40 degrees Celsius. Another method you can use is GI lavage with either an OG-NG or a rectal tube. As far as the gastric tubes go, if your patient is not intubated, then you want to think twice before doing this, because if they are very obtunded, then they do have a big aspiration risk. Peritoneal lavage is mentioned in Tintinelli's, although it seems a slightly easier method between this and pleural lavage, probably pleural lavage. There's two ways. You can do this either with one chest tube or with two chest tubes, and then you can also go on either one side or two sides. If you want to just go one side, the left side is probably better, because in addition to heating the blood that's circulating through the lungs, you're also going to be directly heating the heart and the myocardium. And again, with these fluids, with the GI lavage, peritoneal lavage, pleural lavage, you want to heat to 104 Fahrenheit, 40 degrees Celsius. ECMO, we talked about last month at Journal Club, as a great help in the mortality in cardiac arrest patients. Here is another good instance of another good time when it would be beneficial to the patients, as it can increase their survival rate. I think without ECMO, if they're severely hypothermic, it can be like 33% or so. But with ECMO, it can go up to about 47 or 63% survival rate. So another good reason to consider getting ECMO at your institution. Tintinelli's mentions thoracotomy as a last-ditch effort with mediastinal lavage with warm fluids. It seems like this doesn't offer a great amount of benefit over just doing the pleural lavage as far as the risk versus benefits go. So pleural lavage may just be better. And then the New England Journal paper mentions that If the patient was in cardiac arrest and they were severely hypothermic, meaning less than 28, 30 degrees Celsius, and now you're rewarming them and they're over 32 degrees Celsius and they're still persistently in cardiac arrest, start to consider that this may be a case when you're not going to be able to bring the patient back because you've already rewarmed them over 32 degrees. So those are the techniques as far as rewarming goes. And just to keep in mind, as you are always doing treatment, you want to think what can possibly go wrong. So a few complications that you want to watch out for. First one is rewarming acidosis. If you think about why this happens, you think about how when you start to vasodilate that constricted periphery, as you start to heat things up, you're going to start to bring back the lactate that was likely gathering peripherally. And also, as you start to warm the body up, the metabolic demands are going to increase again, and this is going to probably cause a further increase in oxygen demand, and that'll cause the worsening of the acidosis. Afterdrop is a phenomenon that can occur, that just to keep in mind that this can happen as you heat up the excuse me, as you start to heat the core and you get that vasodilation in the periphery. The cold blood that was essentially stuck in the periphery is going to start to circulate back to the core, and that can cause a further initial drop in your temperature. But just remember that this can be an expected thing and that they should start to get better soon after. As far as heating your fluids and your air goes, remember not to heat anything further than 50 degrees Celsius, 122 Fahrenheit, as this can cause burns and intravascular hemolysis. And then if you're doing the chest tube lavage, remember to watch out for your net fluid balance, obviously. You want to prevent causing something like a tension hydrothorax. I've never personally done chest tube lavage in a hypothermic patient, and so I can't tell you the exact volume that you would use. I've just done the bladder irrigation, but this is kind of the point. The reason I left the question mark there is just if any attendings are listening, then you guys can probably chime in on how much you've done in the past or how much you recommend. My guess is it's going to obviously be based on the size of the patient, meaning like a large man is obviously going to get much more. He's going to be able to handle much more fluid in the thoracic cavity than a small child. And then last point is just the hyperkalemia. It may be scary to see an initial value of 10 or 11 in a patient who is hypothermic, but just know that they have documented survivors with good neurologic outcome with an initial potassium of 11.8. So the New England Journal paper excuse me, recommends a cutoff of 12 as futile. So that does it for this JG Extra. Remember to chime in if you guys have any interesting points to add, especially your attendings out there with any experience with very hypothermic patients. And thank you guys for listening. Take care.